The topic of the tutorial is temporal and infratemporal fossa. I, Dr. Alpana Kesar, will be covering this topic under the following subheads: muscles of mastication, temporomandibular joint, mandibular nerve, otic ganglion, maxillary artery, and pterygoid plexus of veins. Muscles of mastication. There are four muscles of mastication. They are masseter, which is this, temporalis, which is this, medial pterygoid muscle, and lateral pterygoid muscle. In this visual, this is the medial pterygoid and this is the lateral pterygoid. There are three accessory muscles of mastication, which are the suprahyoid muscles. And these accessory muscles of mastication include mylohyoid, geniohyoid, and anterior belly of digastric. These three muscles assist lateral pterygoid muscle in bringing about depression of the mandible. Masseter muscle. Masseter is a quadrilateral shaped muscle that overlies the ramus of mandible. It is a powerful muscle of mastication that helps to elevate the mandible to close the mouth. This muscle has three groups of fibers: superficial, middle, and deep. The origin of all the three groups of fibers is from the zygomatic arch, and the insertion of all the three groups of fibers is on the lateral surface of the ramus of the mandible. The superficial fibers take origin from the lower border of the zygomatic arch at its anterior end. The middle fibers take origin from the lower border at the posterior part, and the deep fibers take origin from the deep surface of the zygomatic arch. The insertion of the superficial fibers is in the lower part of the ramus of the mandible. Middle fibers in the middle part of the ramus, and the deep fibers in the upper part of the ramus of the mandible. Innervation of masseter muscle is by the anterior division of mandibular nerve, which gives a mesenteric branch that supplies the masseter muscle. The origin of masseter is antero-superiorly as compared to the insertion. As a result, the muscle will elevate the mandible, that is, move it upwards to close the mouth, and it will also help to protrude the mandible, that is, move it forwards. Temporalis muscle. Temporalis muscle is a fan-shaped muscle that fills up the entire temporal fossa. This is temporalis muscle and it fills up this temporal fossa. Its origin is from the temporal fossa and temporal fascia that is overlying the temporal fossa. The insertion of temporalis muscle is in the coronoid process and extends down onto the anterior border of the ramus of the mandible. The nerve supply of temporalis muscle is by the deep temporal nerves, which are the branches of anterior division of mandibular nerve. This is the origin of the muscle and this is the insertion. The insertion will move towards the origin and thus the anterior fibers of temporalis are powerful elevators. that elevates the mandible to close the mouth. The posterior fibers of temporalis retract the mandible, thus moving the mandible backwards. Lateral pterygoid muscle. Lateral pterygoid muscle is a triangular or a conical shaped muscle. It is present in the infratemporal fossa. This muscle has two heads, the upper head and the lower head. The upper head takes origin from the infratemporal surface and the infratemporal crest of the greater wing of sphenoid. This is the greater wing of sphenoid, and this is its infratemporal crest, and in light green is the infratemporal surface. The lower head takes origin from the lateral surface of the lateral pterygoid plate. The two heads unite to get inserted into the pterygoid fovea. Pterygoid fovea is a depression on the neck of the mandible. It also gets inserted in the anterior part of the articular disc and the articular capsule of the temporomandibular joint. Innervation of lateral pterygoid muscle is by nerve to lateral pterygoid, which is a branch of anterior trunk of mandibular nerve. The action of lateral pterygoid is to depress the mandible. It is the only muscle of mastication that depresses the mandible to open the mouth. It also helps to protrude the mandible, that is, moves the mandible forwards. Along with medial pterygoid, it also helps in side-to-side movements of the mandible. Medial pterygoid muscle. Medial pterygoid muscle is a quadrangular shaped muscle which is present on the medial surface of the ramus of the mandible in the infratemporal fossa. It has two heads, the superficial head and the deep head. The superficial head takes origin from the tuberosity of maxilla, and the deep head takes origin from the medial surface of the lateral pterygoid plate, marked here with orange. This is the superficial head and this is the deep head. The insertion of medial pterygoid muscle is in the rough triangular area on the medial surface of the ramus of the mandible, close to the angle of the mandible. The nerve supply of medial pterygoid muscle is nerve to medial pterygoid, which is a branch from the main trunk of mandibular nerve. The action of medial pterygoid muscle is to elevate the mandible to close the mouth and to protrude it forwards. It acts along with the lateral pterygoid muscle to bring about side-to-side movement of the jaw. When medial and lateral pterygoid muscles of one side contract, they will move that side of the ramus of the mandible or TMJ medially, and this movement, when alternates with the muscle contraction on the opposite side, will bring about side to side movements of the jaw. We have studied the four muscles of mastication individually and have found that all four of them take origin from the skull and get inserted in the mandible. They help in the movement of mandible. The movements that take place in the mandible are elevation, depression, protrusion, retrusion, and side-to-side movement. Elevation of mandible is brought about by three muscles, namely masseter, temporalis, and medial pterygoid. Masseter and medial pterygoid forms a sling around the ramus of the mandible and function together as strong anti-gravity muscles that helps in the elevation of mandible. Depression of mandible. Lateral pterygoid muscle helps in depression of mandible. This is the only muscle of mastication that helps in depression of mandible. Depression of mandible is assisted by suprahyoid muscles, that is mylohyoid, geniohyoid, and anterior belly of digastric. Depression of mandible is also assisted by gravity. Protrusion of mandible. Protrusion of mandible means thrusting mandible forwards or anteriorly. This movement is brought about by lateral pterygoid muscle, medial pterygoid muscle, and masseter that helps in the anterior or forward movements of mandible. Retrusion of mandible is taking mandible backwards or posteriorly from the protruded position. And this movement is brought about by the posterior fibers of temporalis and the deep fibers of masseter. Side-to-side movements of the mandible. Side-to-side movements of the mandible is brought about by lateral pterygoid muscle and medial pterygoid muscle. When lateral and medial pterygoid muscles contract together on one side, it will bring about medial rotation of mandible on that side. When the movement takes place alternatingly on right and left sides, it will bring about side-to-side chewing movement of the mandible. Temporomandibular joint or TMJ. Temporomandibular joint helps in the movement of mandible, in opening and closing of the mouth, and in side-to-side movements. It is a synovial joint of condylar type. The articulating bones are: the lower articular surface is formed by the head of mandible. The upper articular surface is formed by temporal bone. In the temporal bone, it is formed by articular tubercle and articular fossa, also known as mandibular fossa. So, articular tubercle and articular fossa of the temporal bone articulates with the head of the mandible to form temporomandibular joint. Ligaments of temporomandibular joint. Ligaments are fibrous structures that are attached to the bones around the joint. They help to stabilize the joint and prevents its dislocation. Joint capsule, which encloses a synovial joint, acts like a ligament. So, in temporomandibular joint, the joint capsule is one of the ligaments that encloses the temporomandibular joint complex and is attached above to the articular fossa of the temporal bone and below to the neck of the mandible. It is also attached to the periphery of the articular disc. Extracapsular ligaments. As the name itself suggests, those ligaments which are present outside the joint capsule are called extracapsular ligaments. There are three extracapsular ligaments in temporomandibular joint. They are the lateral ligament, sphenomandibular ligament, and stylomandibular ligament. The lateral ligament is called so because it is present just lateral to the joint capsule. Its fibers runs downwards and backwards. This is the ligament that adds maximum stability to the temporomandibular joint. Sphenomandibular ligament. It is attached above to the spine of sphenoid, and below it is attached to the lingula of the mandible. The third ligament is stylomandibular ligament. It is attached above to the styloid process and below it is attached to the angle of the mandible. This is not a true ligament but rather a thickened part of deep cervical fascia. All these three, that is lateral ligament, sphenomandibular ligament and stylomandibular ligament, adds to the stability of temporomandibular joint and prevents its dislocation. Articular disc. Articular disc is an oval fibrous plate. It is present within the temporomandibular joint space. It has a thick anterior band, a thick posterior band with a thin intermediate zone. The posterior-most part divides into two lamina and is called bilaminar. The superior surface is concavo-convex and the inferior surface is concave. The significance of articular disc is that it divides the entire joint space into two compartments, the lower compartment and the upper compartment. The lower compartment allows rotatory movements of the head of the mandible, as in depression and elevation of mandible. Upper compartment allows gliding and sliding movements that take place during protrusion and retrusion. Articular disc also helps to stabilize the temporomandibular joint. It provides cushioning that helps in shock absorption. It also helps in proprioception, distribution of weight across the joint, and prevents friction. Blood and nerve supply of temporomandibular joint. The blood supply of temporomandibular joint is by maxillary artery and superficial temporal artery, and the nerve supply is by auriculotemporal nerve and mesenteric nerve. Movements of the temporomandibular joint or the functional anatomy of temporomandibular joint. In the temporomandibular joint, the movements on right and left side take place in a coordinated manner. The movements that take place in the mandible are depression to open the mouth, elevation to close the mouth, protrusion or forward movement of the mandible, retraction or backward movement of the mandible, and side-to-side movements. Temporomandibular joint is a complex joint which has articular disc present in its joint space. The articular disc divides the joint space into upper and lower compartments. Upper compartment is also known as meniscotemporal compartment, which is present between the articular disc and the temporal bone. The movement takes place between the articular disc and the articular surface of the temporal bone, in which the sliding and gliding movements takes place to bring about protrusion and retrusion of mandible. The second compartment is meniscomandibular compartment or the lower compartment, which is present between the articular disc and the head of the mandible. This compartment allows rotatory movements of the head of the mandible that takes place during the depression and elevation of mandible to open and close the mouth. Movements of temporomandibular joint. Protrusion. Protrusion is the movement that takes place in the upper compartment. The head of the mandible, along with the articular disc, glides forwards. This movement is brought about by three muscles, and they are lateral pterygoid, medial pterygoid, and superficial fibers of masseter. Retrusion. Retrusion is the movement that takes place in the upper compartment. The head of the mandible, along with the articular disc, glides backwards. The muscles involved in this movement are the posterior fibers of temporalis, deep fibers of masseter, and some assistance is from the suprahyoid muscles, namely geniohyoid and digastric. Next movement of TMJ is depression of the mandible. Depression of the mandible will be understood in two stages: slight opening of the mouth and wide opening of the mouth. In the slight opening of the mouth, the movement takes place in the lower compartment. It involves hinge-like rotatory movements of the head of the mandible on the undersurface of the articular disc. This will lead to depression of the mandible, and thus slight opening of the mouth will take place. For the wide opening of the mouth, the movement will take place in three steps. First, the movement will take place in the lower compartment. Second movement will take place in the upper compartment. And third movement will take place in the lower compartment. The first movement is similar to the movement that occurs at the time of slight opening of the mouth. In this, hinge-like rotatory movements of the head of the mandible takes place on the undersurface of the articular disc, leading to depression of the mandible and slight opening of the mouth. Further rotation of the head of the mandible cannot take place. The movement is restricted by the articular tubercle of the temporal bone. So, to remove this restriction, the head of the mandible glides forwards. The second movement takes place in the upper compartment, where the head of the mandible, along with the articular disc, glides forwards so that the head of the mandible comes to underlie the articular tubercle. Now, the head of the mandible is free to rotate. The third movement takes place in the lower compartment, which involves further rotation of the head of the mandible on the undersurface of the articular disc, leading to further depression of the mandible, and thus wide opening of the mouth occurs. The muscles involved in this movement are the lateral pterygoid muscle, which helps to depress the mandible to open the mouth. This movement is assisted by the suprahyoid muscles, namely digastric, geniohyoid, and mylohyoid. This movement is also assisted by gravity. Elevation of the mandible during the closing of the mouth. The movements that occur during the opening of the mouth are reversed during the closing of the mouth. Powerful muscles are involved in the movement, and they are temporalis, masseter, and medial pterygoid, which are all anti-gravity muscles. Side-to-side movement of the mandible or chewing movements of the mandible. The side-to-side movement of the mandible is brought about by the lateral pterygoid muscles and medial pterygoid muscles when they act together. When the lateral pterygoid muscle and medial pterygoid muscle of one side contract simultaneously, it will bring about medial rotation of the mandible on that side, and thus the chin will move to the opposite side. When the movement taking place on one side occurs alternatingly with the other side, it will lead to side movements of the mandible. Students, don't forget to like this video and subscribe to the channel to stay updated with the latest exam questions. Mandibular nerve is one of the contents of the infratemporal fossa. Mandibular nerve is a branch of trigeminal nerve. Trigeminal nerve has three branches: ophthalmic, maxillary, and mandibular. Of that, mandibular nerve is the largest of the three branches. The ophthalmic and maxillary nerves are purely sensory. Mandibular nerve is a mixed nerve. It has both sensory and motor fibers. Mandibular nerve is topographically related to otic and submandibular ganglion. These are two out of the four parasympathetic ganglion present in the head region. Mandibular nerve is formed from two roots, a large sensory and a small motor root. These two roots exit the cranial cavity by passing through foramen ovale. After passing through foramen ovale, the two roots will enter the infratemporal fossa. In the infratemporal fossa, the two roots unite to form the main trunk of mandibular nerve. The main trunk of mandibular nerve has a very short course in the infratemporal fossa, and immediately after it divides into its two subdivisions, the anterior trunk and the posterior trunk. Branches of mandibular nerve. Mandibular nerve is present in the infratemporal fossa. It has a main trunk which divides into anterior and posterior trunks. The main trunk gives two branches, and they are meningeal branch, also called nervus spinosus, and nerve to medial pterygoid. Main trunk has a short course and it divides into anterior and posterior trunks, of which anterior trunk gives four branches. There is one sensory and three motor branches in the anterior trunk. The sensory branch is buccal nerve, while the rest of the three, that is the mesenteric, deep temporal, and nerve to lateral pterygoid are all motor. The posterior trunk, which is the larger of the two, this is the posterior trunk, gives three branches: auriculotemporal, lingual, and inferior alveolar. Auriculotemporal and lingual are purely sensory, while inferior alveolar is mixed, that is, it has both sensory and motor fibers. Further, we will discuss the course and distribution of each of the branches of mandibular nerve. Starting with the main trunk, the first branch is meningeal branch or nervus spinosus. This is nervus spinosus, which passes through the foramen spinosum to enter the middle cranial fossa. In the middle cranial fossa, nervus spinosus supplies the dura mater. Nerve to medial pterygoid. Nerve to medial pterygoid supplies medial pterygoid muscle and also gives two branches, that is, to tensor villi palatini and tensor tympani. Anterior trunk has four branches. One branch is sensory, called the buccal nerve, which supplies the skin and mucous membrane of cheek. The three motor branches are mesenteric nerve, which supply masseter muscle, nerve to lateral pterygoid, which supplies lateral pterygoid muscle, and deep temporal nerves are two in number and supply temporalis muscle. Posterior trunk of mandibular nerve. Posterior trunk of mandibular nerve has three branches: auriculotemporal, lingual, and inferior alveolar. Each of these branches will be discussed further under the subheads course and distribution. Auriculotemporal nerve. Auriculotemporal nerve is a sensory nerve. It also carries parasympathetic fibers. Auriculotemporal nerve arises from two roots from the posterior trunk of mandibular nerve. The two roots encircle the middle meningeal artery. The two roots join to form the auriculotemporal nerve. The auriculotemporal nerve passes behind the neck of the mandible and then it turns upwards. As it passes upwards, it travels along with the superficial temporal vessels. The area of distribution of auriculotemporal nerve is, it supplies the auricle or the ear, external acoustic meatus and the tympanic membrane. It also supplies the skin of the temple. The name itself suggests auriculotemporal, so it supplies auricle and the temporal region. It also supplies parotid gland and temporomandibular joint. Auriculotemporal nerve carries postganglionic parasympathetic fibers from otic ganglion to the parotid gland. Lingual nerve. Lingual nerve is a branch of posterior trunk of mandibular nerve given off in the infratemporal fossa. This is the infratemporal fossa. This is the posterior trunk of mandibular nerve, and this is the lingual nerve. After arising from the posterior trunk of mandibular nerve, the lingual nerve runs between the medial and the lateral pterygoid muscles. Medial pterygoid muscle is present medial to the lingual nerve, and lateral pterygoid muscle is present lateral to the lingual nerve. Lingual nerve is then joined by cauda tympani nerve, which is a branch of facial nerve. After this, lingual nerve enters the oral cavity. In the oral cavity, the lingual nerve runs in a shallow groove on the medial surface of the mandible, just inferior to the third molar teeth. In this position, it is in the danger of getting damaged at the time of surgical procedures performed on the molar teeth, such as extractions of the impacted third molar teeth. It is also associated with the submandibular ganglion in this region. From there, the lingual nerve enters the floor of the mouth. In the floor of the mouth, it runs over mylohyoid and geniohyoid muscles. In the floor of the mouth, the lingual nerve winds around the submandibular gland duct and finally divides into its terminal branches. When it winds around the submandibular gland duct, it is in the danger of getting damaged at the time of surgeries performed on sublingual gland duct. Such surgeries are required for procedures like removal of stones that may be formed in the duct. These surgeries must be performed carefully so as not to damage the lingual nerve. Distribution of lingual nerve. Lingual nerve is sensory to the anterior two-thirds of the tongue and carries the sensation of touch, temperature, and pain from the anterior two-thirds of the tongue. It is also sensory to the floor of the oral cavity. The fibers of cauda tympani are distributed via lingual nerve, and these fibers are gustatory to the anterior two-thirds of the tongue, that is, carries taste sensations from the anterior two-thirds of the tongue. They are also secretomotor to submandibular and sublingual salivary glands. Inferior alveolar nerve. Inferior alveolar nerve is a branch of posterior trunk of mandibular nerve. It arises in the infratemporal fossa. It leaves the infratemporal fossa by passing through mandibular foramen. Just before it enters the mandibular foramen, it gives a branch called nerve to mylohyoid. Nerve to mylohyoid supplies mylohyoid muscle and the anterior belly of digastric. After this, the nerve continues in the mandibular canal within the body of mandible. As it traverses through the mandibular canal, it gives branches to the molars and the premolars. As the inferior alveolar nerve reaches the mental foramen, it divides into its two terminal branches. They are the mental nerve and the incisive branch. The incisive branch continues forwards in the mandibular canal and supplies the incisors and the canines. The mental nerve comes out through the mental foramen and supplies the skin and the mucosa of the chin and the lower lip. Distribution of inferior alveolar nerve. Inferior alveolar nerve is a mixed nerve that has both sensory and motor fibers. Inferior alveolar nerve is sensory to the molars and the premolars, along with the surrounding gums. Its incisive branch is sensory to incisors and canines and the surrounding gums. The mental nerve is sensory to the skin and mucous membrane of lower lip and chin. Nerve to mylohyoid, which is a branch given off by the inferior alveolar nerve just before it enters the mandibular foramen, supplies mylohyoid muscle and anterior belly of digastric. Inferior alveolar nerve block. Inferior alveolar nerve block is used to block the inferior alveolar nerve. In this, anesthesia is deposited around the inferior alveolar nerve at the mandibular foramen. It helps to anesthetize the area of distribution of inferior alveolar nerve. This is required to perform surgical procedures on all the mandibular teeth and the surrounding gums. Otic ganglion. Otic ganglion is yet another structure present in the infratemporal fossa. It is one of the 4 parasympathetic ganglion present in the region of head. It relays secretomotor fibers to parotid gland and controls the secretions of parotid gland. It is topographically related to mandibular nerve. It is present in association with mandibular nerve's main trunk just below foramen ovale. It is functionally related to glossopharyngeal nerve. The preganglionic parasympathetic fibers to the otic ganglion reach through the branches of glossopharyngeal nerve and thus control it. Otic ganglion is 2 to 3 millimeters in size and it is located in the infratemporal fossa just below foramen ovale in association with the main trunk of mandibular nerve. Parasympathetic pathway of otic ganglion. The parasympathetic pathway of otic ganglion begins in the brainstem. The preganglionic parasympathetic fibers arise from the inferior salivatory nucleus in the brainstem. These fibers pass in the glossopharyngeal nerve. Then it passes into its tympanic branch, into the tympanic plexus. From the tympanic plexus arises the lesser petrosal nerve, which carries these preganglionic fibers to the otic ganglion. These fibers relay into the otic ganglion. The postganglionic fibers arising from the otic ganglion pass into the auriculotemporal nerve to reach the parotid gland. Thus, it controls the secretions of the parotid gland. Sympathetic root of otic ganglion. The postganglionic fibers arise from the superior cervical ganglion. These fibers pass through the otic ganglion without relaying into it. The fibers further pass into the auriculotemporal nerve to reach the parotid gland. In the parotid gland, these fibers are vasomotor. They control the blood flow to the parotid gland. The sympathetic fibers only pass through the otic ganglion and do not relay into it. The sensory root arises from the auriculotemporal nerve and is sensory to the parotid gland. Maxillary artery. Maxillary artery is yet another structure present in the infratemporal fossa. It arises as one of the terminal branches of external carotid artery. It arises behind the neck of the mandible. After that, the artery passes through the infratemporal fossa and then into the pterygopalatine fossa. In the infratemporal fossa, maxillary artery gives numerous branches. Via its numerous branches, it has a wide area of supply, and it supplies ear, dura mater, upper and lower jaws, temporal and infratemporal regions, nose and paranasal air sinuses, and palate. Maxillary artery has three parts. Of maxillary artery are the mandibular part, the pterygoid part, and the pterygopalatine part. Each of the part of maxillary artery gives several branches. The first part of maxillary artery gives 5 branches. 2 branches supply the structure of ear, 2 arteries supply the meninges, and 1 branch supplies the teeth. The 5 branches are deep auricular, anterior tympanic, middle meningeal, accessory meningeal, and inferior alveolar. Deep auricular passes through foramen in the floor of external acoustic meatus. It supplies external acoustic meatus and tympanic membrane. Anterior tympanic passes through petrotympanic fissure. It supplies inner surface of tympanic membrane. Middle meningeal artery passes through foramen spinosum to enter the middle cranial fossa. It supplies bone and meninges in the middle cranial fossa. Accessory meningeal artery passes through foramen ovale and supplies meninges in the middle cranial fossa. Inferior alveolar artery passes through mandibular foramen and supplies the lower teeth and mylohyoid muscle. The first 2 branches of the first part of maxillary artery are deep auricular and anterior tympanic, which are these, and go to the structure of the ear. The 2 branches for after that are accessory meningeal artery and middle meningeal artery, which passes upwards and pass through the foramina in the base of the skull, that is foramen spinosum and foramen ovale, to enter the middle cranial fossa. And a branch arising from its inferior surface is inferior alveolar artery that travels along with the inferior alveolar nerve in the mandibular foramen and mandibular canal to supply all the teeth. Second part of maxillary artery gives 4 branches. They are mesenteric artery, deep temporal artery, pterygoid artery, and buccal artery. These 4 arteries travel with the 4 nerves that are the branches of anterior trunk of mandibular nerve. This is the mesenteric artery, deep temporal artery, pterygoid artery, and buccal artery. In this is the mesenteric artery. These are the deep temporal arteries, the pterygoid arteries, and the buccal artery. The mesenteric artery supplies masseter muscle The deep temporal arteries supplies temporalis. The pterygoid artery supplies lateral and medial pterygoid, and buccal artery supplies the skin and the mucosa of the cheek. Third part of maxillary artery is the part which is present in the pterygopalatine fossa and is also called the pterygopalatine part. The branches of third part of maxillary artery accompanies the branches of maxillary nerve. The branches of third part of maxillary artery are the posterior superior alveolar artery, which supplies the upper molar and the premolar teeth. It also supplies maxillary air sinus. Greater palatine artery, which supplies palate and tonsils. Infraorbital artery accompanies infraorbital nerve and supplies orbital muscles, maxillary air sinus, and maxillary canines and incisors. Pharyngeal artery supplies nose, pharynx, and auditory tube. Artery of the pterygoid canal supplies auditory tube, pharynx, and middle ear. Sphenopalatine artery supplies nose and air sinuses. Pterygoid plexus of veins is a network of veins present in the infratemporal fossa around the lateral pterygoid muscle. Its tributaries correspond to the branches of maxillary artery. The veins that accompany the branches of maxillary artery and drain blood from the area supplied by the branches of maxillary artery will drain into pterygoid plexus of veins. After that, the pterygoid plexus of veins will drain into maxillary vein, and maxillary vein joins with the superficial temporal vein to form the retromandibular vein. Pterygoid plexus of veins communicates with the veins around it, which forms some important clinically relevant connections. It communicates with the inferior ophthalmic vein via the inferior orbital fissure. It communicates with the cavernous sinus through emissary vein. It also communicates with the facial vein through the deep facial veins. Infratemporal fossa is a very important exam topic for the dental students. Students should be thorough with each and every part of the topic infratemporal fossa. Some of the frequently asked questions from the topic infratemporal fossa include: describe all the four muscles of mastication, namely masseter, temporalis, medial pterygoid, and lateral pterygoid, under the following heads, that is origin, insertion, nerve supply, action, and relations. Sometimes a single muscle may be asked, such as say lateral pterygoid, which must be described under the same subheads, that is origin, insertion, nerve supply, action, and relations. Sometimes simply enumeration of the muscles of mastication may be asked. Next important topic that is often asked in the exam include: describe temporomandibular joint under the following subheads: type of joint, articulating bones, ligaments of the joint, relations of the joint, and movements of the temporomandibular joint. Functional anatomy of temporomandibular joint or movements of temporomandibular joint is one and the same. Next, very important question asked from the topic is formation, course, branches and distribution of mandibular nerve. Mandibular nerve may be asked as a complete question or any of its part may be asked as a small question or short note. For example, short notes on lingual nerve and inferior alveolar nerves. Yet another topic is maxillary artery. And the question that may be asked is describe maxillary artery under the following heads: origin, parts of maxillary artery, course or relation of each of the part of maxillary artery, its branches, and area of distribution of its branches. Otic ganglion, which is the content of the infratemporal fossa, may also be asked as a short note. A short note on pterygoid plexus of veins may be asked. Applied anatomy or clinical questions related to infratemporal fossa include nerve supply of the mandibular teeth, inferior alveolar nerve block, clinical significance of relation of lingual nerve to the mandible. Lingual nerve is related to the lingual plate of third molar tooth in the mandible, where it is in the danger of getting damage if there is fracture of the lingual plate at the time of removal of the third molar tooth. Relations of the lingual nerve to the submandibular gland duct. The lingual nerve winds around the submandibular gland duct in the floor of the mouth. At the time of removal of stones from the submandibular gland duct, lingual nerve must be spared or saved. Any damage to the lingual nerve will result in anesthesia or paresthesia, that is, either loss of sensation or altered sensations in the tongue.